Hello, everyone. Good afternoon, and thank you. Welcome to those who have already joined. Let's please give one more minute to the rest of the people to log in, and then we can kickstart today's session. To begin with, my name is Anna, and I'm the Innovation Lead of Galen Growth. And today I have the pleasure to be the moderator of the soon-to-begin panel discussion. I do indeed have an amazing lineup of professionals. Some of them are sitting here with me on my left, and one is already connected virtually. They are going to share with you their expertise, insights, experience, but also answer all of your questions. So please do use the chat function on the right side of Teams, and we will be recovering them at the end of the discussion. For those of you who are not familiar with the records, well, this is a series of events that we, Galen Growth, have been crafting in collaboration with BIOME Novartis. Indeed, we are broadcasting live from BIOME lab space here at Maple Tree in full social distance measures. You don't see him, but sitting across me, there's my co-producer and head of BIOME, Christian Theo. Hi, Chris. The objective of these events is to bring digital health topics to a wider audience, of course, and introduce you to the people who are behind the disruptive solutions and exactly those people who are shaping the future of health. The past sessions were on telemedicine and oncology. In October, we are going to have one dedicated to mental health. Quite a dynamic area, but also quite a sensitive topic for all of us, and especially in these particular times. Moving through November, we are going to have the Pharma Innovation Index, where we are going to explore how pharmacos have been doing in digital health innovation, but also how they compare to each other, which is quite insightful. And we are going to wrap up the year with the digital health readiness assessment of selected countries. So it's going to be more of a macro view on digital health throughout the year. So just stay tuned. We are going to share all the information on our social media channels, and interesting times ahead. Okay, without any further ado, let me please introduce the panelists for today's session, remote patient monitoring. And connected, joining me today, there is Dr. Valerie Theo, there is Ronald Ling, Amrish Nair, and Jonathan Tan. And with the principle of ladies first, please, Valerie, introduce yourself.
Hi, good afternoon, everyone. I'm Valerie. I'm a consultant family physician practicing at the National Healthcare Group Polyclinics. I'm currently the head of one of the Polyclinics. So in terms of remote patient monitoring, so I'm also the clinical lead in some of our new experiments or our new moves towards digital health and telemedicine. So I help with some of the projects involved in remote patient monitoring and looking at some innovation projects. So looking forward to having this session with you today. Thank you.
Hi, thanks, Anna. I'm Ronald Ling. I'm CEO of Connected Health, which is a startup company. We've been around for about 4 years, based here in Singapore. My original background is as a medical doctor, but that was way back. Since then, I've been involved mainly in business and investments in healthcare, but most closely involved with Parkway Holdings, the large private healthcare group, for many years as an investor and a board member. And my perspective on digital health is really as a sort of a late bloomer entrepreneur in some respects. I feel sometimes I'm too old to be an entrepreneur, but I think it's probably not a bad thing to have some sort of experience and industry knowledge going into this, especially a complex field like this. But I look forward to sharing with you our views on what it takes to build a successful digital health business, which is truly transformational, in our case in diabetes.
Yep. Hello, my name's Amrish. I'm the co-founder of Biorithm. We're a company innovating in the space of maternal and fetal health, and broadly in women's health, and really solving the problems of access to healthcare and preventable poor outcomes. Many people often forget that pregnancy is not a disease. It's not something you treat; it's something you manage. And making the process, including women in that process, as a key stakeholder, as a key partner in their healthcare is absolutely essential. And that's exactly what we do. We engage them in a much more meaningful way than currently is in pregnancy care. And the whole goal is to expand the scope of healthcare beyond the four walls of the hospital. And, we're building remote monitoring systems from devices, mobile apps, as well as platforms to both, improve that access as well as prevent poor outcomes. So, yeah, thank you.
Hi, everyone. Jonathan here. So I look after patient access for Novartis in Asia. And, I think patient access traditionally was really focused on, convincing governments, payers to, fund our medicines, right, from pharma. But I think more and more we're seeing that, pharma does need to think more broadly, right? And so I think as we will share more later, our ideas and some of the initiatives we're doing really to, let's say, disrupt how pharma interacts with the healthcare system, right? Going beyond the pill, as we often hear, because ultimately it's, I think the medicine alone, everyone recognizes is not enough, right? There's so many other issues, barriers, challenges that we need to help solve in order to really maximize the outcomes for the patients, right? And so remote monitoring is certainly one of them. And so really looking forward to this discussion with the panel. Thanks.
Fantastic. Thank you so much to all. It's going to be quite an interesting conversation. Okay, let me just set a bit the scene and introduce what is remote patient monitoring. Probably not necessary for you, but at least for our audience. So what is remote patient monitoring, right? It refers to all those tech solutions that aim to monitor patients' health outside of the traditional clinical setting, be it their personal homes, houses, another care facility, or any remote area that offers coverage and, of course, internet connection. It ranges from monitoring vital signs to tracking, of course, mental states, to collecting, but also sharing daily information, for example, on medication dosages. These information are shared, of course, either via telecommunication or automatically because connected to the HCP health record system, or they are stored locally to be shared and consulted at a later stage. Globally, remote patient monitoring has seen an increase in funding of 38% compared to 2019. You should probably expect that US is leading the race with a CAGR of 27%, and it is followed by Europe and the Middle East. APAC region remains relevant in terms of course, absolute values, both in number of ventures, but also in total funding deployed. However, we mentioned other regions are growing at a faster pace. Obviously, these data points agree that there is a momentum going on, there is change underway, and most of all, there is need for remote patient monitoring. Okay, I would like to open the panel and explore the need factor with two of the entrepreneurs on the stage that are actively involved in remote patient monitoring. Why are remote patient monitoring solutions needed in today's world? What are the advantages and disadvantages? Who would like to share? Who would like to start first?
I can go ahead. Okay. Well, let's talk a bit about diabetes. So Connected Health has a product called SugarSure, which will be launching commercially in Singapore around the end of this year. So just by way of background, what SugarSure is basically an app which is connected to a clinical data platform, which also connects to the doctor and also a health coach who is a registered nurse. So we have a virtual care team, which is connected through our platform, which basically takes the data which is fed in by the patient. The patient does have to enter data on their blood glucose, their diet, of their weight, and various other factors, and then analyzes the data and then alerts the patient if there's something that's going off track, the doctor or the health coach as well. So it's a way of coordinating things and providing ultimately more closely monitored care, and we believe this will result in better outcomes. Now, why is this important, and why have we done this? Why have I invested 4 years of my time in this? Because we have a problem. I mean, Singapore has talked for many years now about the war on diabetes. And it's true, we do have a high prevalence of diabetes here. And more importantly, I would say that we have actually relatively outcomes that can be improved, that need to be improved. One thing which struck me particularly is that the percentage of end-stage renal failure patients here in Singapore who have diabetes as the primary cause of that renal failure is very high. It's about, I think, 75%. It's about the highest in the world, which means to me, it tells me that we're doing something not quite right. We can really improve how we manage patients so that we ideally will prevent them from getting to this stage. So my thesis is that the current healthcare system is in some way not able to provide the kind of support and education that that the patients may need to get there. So there's a gap first in the delivery systems. Secondly, well, where does remote monitoring fit in? There's also a gap in resources, and one of the reasons why there is a gap is because we just don't have enough nurses. The GPs who treat many patients in diabetes are very pressed for time. The average consultation time is maybe 5 minutes or less even. And so diabetes patients, like many chronic disease patients, need a lot more time. And so how do you deliver that effectively? How do you do it in a way which is cost effective, where you have scarce resources? The answer is remote monitoring, telemedicine. And that's, to me, one of the strongest arguments. So put together the need for it in terms of the unmet or unsatisfied outcomes, the shortage of resources, and then the third factor, just to finish on this question, is the financial cost of this all. Right now, if you project out what the cost to society is going to be in 20 or 30 years if we don't do something about this diabetes epidemic, we won't be able to afford to treat all the cases of kidney failure and heart problems and eye issues, etc., because it will explode basically. So there is I would say, really a necessity. There's a prerogative for society as a whole to address this. And so my strong view is that telemedicine and remote monitoring has to have a place in transforming healthcare. And so this is what we're trying to do with Sugarshaw.
Yeah, and I think for me, it really boils down to two things, right? It's about money and outcomes. And that's the brutal truth of it. And, it's how we deliver value and value-based healthcare. And in order to do that, we got to see health as continuous. And the way we do things are currently very episodic. It's within the four walls of the hospital. And so there's a huge, I would say, there's a huge disparity between treating healthcare as continuous in the home or outside of the hospital, and the fact that we still go to the hospital for all our healthcare needs. And the paradigm that we have adopted here at Biorithm is one of risk assessment. How do we get the highest risk patients to the care they need? And by that, assessing their static risk and their dynamic risk as they progress through the disease. And I think that's the most important thing that remote monitoring can do. It's provide an almost live update on the risk status of the patient as she goes through her care. And this can evolve through different maternal morbidities, mental health, physiological diabetes, hypertension, fetal health. And how do we make sure that assessment provides for a healthy and happy mother and baby at the end of 9 months? And I liken this to very much where cardiology was 40 years ago. If you ask cardiologists, where would they be without the Holter monitor? Where would they be without the loop recorder? Where would they be without being able to observe patients at home? I can very much tell you they'll be in a very different state than they are today. The knowledge that we have in order to treat patients is so much more advanced because we know what happens outside the hospital. And that's the same for obstetrics. Obstetrics is where cardiology was 40 years ago. Everything happens in the hospital. Not all events happen in that 1% of the time that you're in hospital. And I think that's the importance of remote monitoring. It's capturing that 99% without burdening the doctors, but providing the right patients into the hospital so they can treat them and do their jobs well. So that is the essence of remote monitoring. And with that, we introduced FEMA, which is our remote monitoring platform, which provides for not just maternal monitoring, but very importantly, fetal monitoring, which can assess a patient which, well, I would say is the smallest patient in the world. as well as, a patient you can't see, touch, feel, a patient who can't tell you what's wrong. And I think providing that baby bit is so essential to assessing a pregnancy as a whole, mother and fetus. So, I mean, at Biorithm, essentially, that's what we do. Capturing the pregnancy as a whole, being able to relay that information to the doctors in a risk-adjusted way, and being able to bring patients back so that there can be a happy outcome at the end of 9 months. Yeah, and that's what it means to us.
That's fantastic. No, thank you both for sharing. Also, the impact that you are producing with your ventures. The next question actually was indeed on how your individual ventures are working and how they are trying to solve these pain points. You more or less touched in this answer. Would you like to share more on your individual key strengths of the ventures and how effective the companies are being in solving indeed these pain points?
Yes, so a lot of people tell me, they ask me, well, why are you involved in diabetes? It's a competitive space. There are lots of people who have apps out there. It's a competitive space. Why are we doing this? Well, my response to this, firstly, just by way of sort of responding to your question, is that, well, if it's competitive, tell me what's the penetration, what's the current usage of digital tools in remote monitoring for diabetes. In Asia, it's next to zero still. So to me, that tells me that the existing players who are trying to find solutions haven't quite got it right yet. And this is borne out by there are various pieces of scientific research which say that, and also anecdotally, if you look at the various solutions on the market, they are generally what I call piecemeal. They will look at one aspect of diabetes. They will look at diet, or they may look at just the blood glucose levels and track those. But diabetes is a very complicated and holistic. It needs to be looked at holistically. And to take the point about sort of medication and the synergies earlier on, one thing that I think has really not been looked at very fully by existing approaches is the relationship between how do you actually have synergistic medical as well as lifestyle management. Now, if you look at actually the indication for all diabetes drugs, they are all designed to be used in conjunction with active lifestyle management. Now, how many actual diabetics who receive these drugs receive that lifestyle management? It's really next to zero at the moment. So we, from the very beginning with SugarSure, have said we will take a holistic approach to diabetes. We will measure and monitor a whole variety of indicators, which means that our product is complex. But we will, from the beginning, take a holistic approach so that you can look at the interrelationships, such as with medication and other things. And so as a result of that, we've come up with a product which is rather more complicated than some of the existing apps in the market. And it's much more than an app. SugarSure is actually a mixture of a diabetes electronic medical record, a patient app, and it actually even has bundled health coaching services, which are packaged for the patient. So I believe diabetes is complicated. Chronic diseases in general are complicated, but diabetes, we happen to pick the most complicated, I think, to start with. You need the right design of solution, and then you need the right business models to implement it as well, which I think is perhaps going to be your next question. One of the questions that we face as a startup is, well, do we have the right business model? How are people going to pay for it? In our cases, how are we going to align incentives with the doctors who also need to be users here to have the doctors spend a bit of time doing some remote monitoring? Because it needs a bit of time from the doctors. It will, I believe, result in better results because you'll be able to solve problems earlier by remote monitoring. But how do you make the economics work for the overall ecosystem? Who pays for it? And then later on, I think we'll come into the issues around insurance companies and governments. And there are broader issues, again, around the health economics of all of this kind of stuff. So without really wanting to sort of get into those questions just yet, I'm just really opening up the discussion, I guess, to bring these points to the fore. These are all things that we do have a view on, of course, for SugarSure, and that's part of our business plan. I'll discuss parts of it if you ask me, but I'm just really highlighting the complexity of it and highlighting also the fact that so far, whilst there are many apps in the market, really none of them has really made it so far, at least in Asia. So we are entering a very open market still, I would say.
Well, that created a lot of curiosity around it. So allow me, asking a bit my panelists, allow me to change a bit the flow. Let's deep dive and finish connected health in this case. And then we start again with Biorhythm on pain points and the business model and how effective you have been. So Ronald, please go ahead.
Okay, well, would you like me to talk about business models or? Okay, so so for us, let me just describe what our business model is at the moment, and we are just soon to launch our commercial version of SugarSure, and that is so far it's going to be initially targeted at the private sector. So that's why we haven't had extensive discussions with Valerie yet. Although we would love to have these discussions around collaboration with the public sector and the clusters. But we know that, so we believe that the starting point is actually the private sector. And that's perhaps where there's the most need as well, I would say, because at least in Singapore, and I do think the same is true outside around Asia as well, generally the private GPs are the ones who are least well equipped to manage or to support chronic diseases like diabetes. Now, there are various measures that the government is trying to put in place to give them support and shared services, and that will I believe, help. But nevertheless, we are still facing the situation where you have individual doctors with limited resources, limited time, not able to really provide the support that you need. So what's the solution here? How do we align ourselves so that these people, these doctors, will actually adopt SugarSure and recommend it to the patients and support or be enthusiastic about motivating the patients to adopt this? One of the big issues with many of these solutions around chronic diseases is patient adoption and getting patients to adhere to the protocols and all of this which we put in place. So I believe, and we believe at Connected Health, that the role of the physician is important here. That's why the physician is part of the care team that is an integral part of delivering the support that SugarSure helps. And also, it does in fact boil down to dollars and cents at the moment. So just again, this is the reality of things. For many of the private doctors, they want to have a solution which is going to improve their patients' care. Number one, of course, is always the care that you give to your patients, but to do it in a way that is actually cost effective for them. It doesn't involve a huge amount of time for them being spent on remote monitoring and all the additional time sinks, which potentially digital health might create. So we have designed a product which we believe is very workflow efficient for the doctors, and we support that with nurses and the kind of services which the independent GPs cannot provide by themselves. So it's kind of like a virtual system where we have these shared resources delivered by us, and we make it very easy for the doctors, individual doctors, to use SugarSure. And then we market the product to both doctors and to patients. Now, adoption I think will be slow with doctors. I'm prepared to see that the sort of number of doctors running and jumping to take up SugarSure we'll have a number of innovative doctors, but many of them will wait and see. But I believe the pull from patients, if we market this right, will be very significant. And then we will perhaps like has happened with some pharmaceuticals, you might market it partly to the patients, and then if they ask their doctors about it, maybe then they will gradually sort of bring the doctors along. I'm not sure yet. It remains to be seen. We're just marketing it. But these are some of the questions and some of the challenges, I would say, that we face in terms of getting penetration in what we believe will be truly transformational.
That's definitely quite exhaustive, and I would be happy also to be curious to have like some kind of a check-in, and see how things are progressing. Okay, great. Okay, the 6 months time, it was the timeline shared. Amrish, your turn. What about Biorhythm? How you are solving the pain points, and how you are going to the market?
So just to reiterate, FEMAM is a remote monitoring platform for maternal and fetal health. And the way we deliver the system is physicians get to prescribe virtual visits which mothers can then conduct themselves at home. So be it patient-reported outcomes, off-the-shelf measurements like BP glucose, and finally fetal monitoring. And in these sessions, which can last for 2 minutes from a blood pressure measurement to 40 minutes for a fetal monitoring measurement, these measurements are then sent across back to the clinical platform. They're triaged, red, yellow, green. So the whole principle behind this is right information to the right person at the right time. And I mean, if you look at all these consulting decks, you'll see these lovely overlapping circles and triangles, which always ends up with the nurse in the middle. So it's, you know, we see that as a central point of information where the nursing and midwifery staff reliably escalate cases to the clinicians. And so that way you get the most efficient flow. So when you look at this, the biggest pain points, and you know, our expertise started off with physiological monitoring and sensing. That's what we do really well. Like I said, you know, we can monitor a patient with whom you can't even see or touch, and we can do it reliably by patient monitoring themselves. But we realize as a company, to deliver that right information to the right person at the right time, we need to become experts in a whole range of things. You know, IT systems to integrate into the hospitals. What does an EMR look like? Interoperability with different systems, clinical data workflow, visualization so people can accurately diagnose without, you know, making mistakes. So all these things come into play. And, you know, Ronald brought up a great point. It's about aligning incentives and aligning motivations. And once you do that, everything else just becomes details. But the aligning of motivations, actually, it's a far more complex process. And in remote patient monitoring touches so many of these stakeholders beyond the physician and the patient. I talked about nursing midwifery. I talked about IT systems and support. You know, you speak then to the biomedical engineers who support the devices that you're rolling out. So it's more than just patient and provider. It's actually all these stakeholders that have their motivations aligned. And so that's one of the biggest pain points, I would say, in rolling out remote patient monitoring. And I'm sure the other panelists may share my view as well to some extent. And it's about having a business model that allows you to scale up and scale down according to the patient needs and risks. So one solution doesn't fit all our patients. And that's why we have stratified FEMAM into two layers, one for maternal monitoring and the next one for maternal and fetal monitoring, whereby maternal monitoring applies to a much more broader segment of patients, which will come at a lower cost, including blood pressure, glucose, diabetes, which acts as a screening and monitoring tool, and then the fetal monitoring component, which involves specialist devices and much higher acuity information. So it's really about stratifying your solution and providing monitoring as a service, as we like to call it, that would really fit into the different reimbursement and payment models in different countries. You have the capitation models in the UK and Australia, where they're given fixed sums of money for a lot of people, and they have to find ways to save money to keep patients out of hospital. You have the models in the US, which are reimbursement based. So monitoring as a service actually fits and aligns with all these models because it provides value, especially for patients who require frequent monitoring, be it diabetes, glucose, and fetal monitoring. And one unique thing about OBGYN is that the department generally owns the patient. Internal medicine, you have a little bit of an issue where you have the endocrine wants this, you know, the cardiologist wants this, the pulmonologist wants this, the renal physician wants this. In OBGYN, we're able to aggregate all this data and provide it to the physician. And again, you know, right data, right person, right time. And that would lead to savings and better outcomes for us. So yeah, that's essentially how that's essentially the philosophy behind FEMAM and Biorhythm's product.
Fantastic. Thank you so much for that. You both already mentioned the stakeholders and the potential partners that will help you succeed in bringing to market the solution. And two of these stakeholders are today with us. So I would start with Dr. Valerie Teo in this case. With National Healthcare Group Polyclinics, you have launched the Remote Vital Signs Monitoring Telehealth Program, which is quite an important name. Tell us a bit more about it, the motivations behind it, and the rationale.
So coming from the public sector, I think some of the issues that we face might be a little bit different, I guess, from the private sector. So in the public healthcare system, an average polyclinic can see anywhere from 600 to 2,000 patients a day. That alone will get anybody cringing in their seats. It can get busy, and of course with COVID, that has added a whole different layer of difficulty and challenges. So we wanted to see how we could then augment care for patients with chronic diseases. And we started looking at hypertension first because that was a group that we know is easy to monitor remotely. There was nothing too invasive because patients are relatively sensitive when you want to ask them to prick their fingers at home or do anything more invasive. So we started with that. So we had a pilot looking at having remote monitoring for their blood pressure with a Bluetooth enabled system that then automatically sends their readings to a cloud, which then comes to their healthcare provider, which is us in the polyclinics, and we get to monitor them over time. So of course, to set up the system, the team needed to build up algorithms to make sure if there were patients that hit certain thresholds, we would get messages to them through a chatbot to tell them to seek help if they need it. And monthly, we will also get an aggregate of their blood pressure readings. And if we needed to intervene because the blood pressures went up or were not in the desirable range, then the care provider can then trigger a teleconsultation, call them, adjust the medications, or provide some health and lifestyle advice, and then monitor them for the subsequent months. So we actually did our pilot in 2018 to 2019, and the results were actually pretty good, which is why we then subsequently started to roll this out to all the polyclinics last year. Of course, it's been a little bit slower because of COVID, so that has added some challenges. But I mean, through the pilot, what we found was, firstly, of course, we looked at the hard data, right? So the blood pressure readings improved, the systolic blood pressures, the diastolic blood pressures improved over a 6-month period. The proportion of patients with good control compared to the usual care, that also went up. And the odds of you having good blood pressure by the end of 6 months was much higher. So that was just the hard data. Then, of course, I think everybody's looking at value. So we also looked at so we looked at the cost effectiveness of such a solution. Was it going to be something sustainable for a public healthcare system? Is this something we really want to go into? So we actually found that based on WHO's criteria for ICERs, we were very cost effective. So this is a solution that in the long run was going to save the healthcare system money after the solution can be deployed, of course, more readily to all public polyclinics. And of course, we wanted to look at the softer side of things. So I think it's often difficult to understand what the patients really want, where they're coming from, what are the things they need. So we actually did small focus groups and individual interviews with the patients we piloted this solution on. And a lot of the insights that we gathered in adjusting and improving the system actually came from that. So patients, of course, they want value, right? They want to make sure that subsidies are reasonable, that the price point is still reasonable. They also want to be assured that somebody really is monitoring them. I think a lot of them are concerned that they are sending the readings, but they don't really know what happens in the back end. Is somebody really watching them? Is somebody going to intervene if I need help? And being able to reassure them that there's somebody who really gets in touch when something goes wrong, that helps to reinforce that this system works for them. And the most important behavior that we wanted to inculcate or to motivate was really patient self-monitoring for them to be empowered to manage these on their own. If you've got hypertension for many years, there's not much value add in seeing a physician every 6 months to tell you the same thing that you've heard and you know. But it's more important for them to know week on week how their blood pressure is doing. Are there things I need to do? Am I slipping up? Am I eating more recently? Do I need to cut back because my blood pressures are going up? And this behavior is really important. And that's what we found has really improved through this system. When we first started the project, about 50% of their patients kept to their once-a-week schedule of doing it. And after the chatbot kicked in and the full system kicked in, we've got that up to about 80 to 90%. So 80 to 90% of our patients are actually monitoring their blood pressure on their own at least once a week. And of course, you've got the really good patients who even monitor them up to 30, 40 times a day, which is okay. At least they do feel reassured. And you know that it's at the right motivation, right? Because they want to know how they're doing and to improve that. So coming from the public healthcare perspective, I think the main challenges in terms of sustainability is how do we continue to improve taking this patient feedback or our clients' feedback into consideration, because sometimes what a clinician wants and what our patient wants are completely different, right? And it's hard to sometimes reconcile that. As a family physician, sometimes I think, shouldn't the patient already know this? Shouldn't you want to do this? But there are a lot of things out there that we may not understand in the background. So we try to incorporate that. And in the success of this project, it's really about us being nimble. So from our prototype, when we first started the pilot, to the product that we're rolling out right now, we've gone through like 4 or 5 iterations. We've changed how the dashboard looks for the clinicians. We've changed how the app looks for the patient, from bringing home an extra handphone just to send the Bluetooth BP readings to now having it all integrated in one application, including the chatbot. So I think there was a question in the chat that asked, why didn't it work last time? Why is it working better now? I think we did try to do this some years back. It wasn't so successful because we weren't maybe as nimble at that time to modify things as quickly. And I think now with COVID and with the rapid changing technology, we've had the opportunity to do that much faster. So hopefully that continues to contribute to further success.
Super interesting. I just want to anticipate you that at the beginning, I was asked if the panelists can ask questions to the panelists. So we're going to have 5 minutes to that, and I think some will be directed to yourself.
Okay.
Thank you for answering. You actually covered also the other topics that were part of the questions. I just would ask you a bit more about the future. Where do you see this initiative going? What's the next stage of that, if there is any vision for the future?
So I think for us, the next step is really trying to bring solutions together. I think integration to our electronic medical records, that's something that's at the back of everybody's minds, because you don't want to have every pilot runs on a different system. Before you know it, the poor clinician is sitting there with 20 applications opened, and he doesn't know which one to click when the patient comes and sits in front of him. So integration, I think that's something we're going to look at in the long run. And for us, we really wanted to start with hypertension, but we do have plans to layer on other chronic diseases. But we wanted that base platform to be mature so that whatever we added onto it just augments care more and more, rather than creating new solutions for various chronic conditions. So that's probably what we're looking for in the future. And also through COVID, we've done a lot more teleconsultation, so video consultations with our patients. So how do we continue to integrate this together and reduce the need for patients to come and see us face to face? Yeah. And for them, as you mentioned, for it to be convenient for them to do things on the go, to be able to still monitor their health from home.
Fantastic. Thank you for that. I will not continue with questions. I will leave to the panelists for later. Let's change stakeholder to the initial conversation. Jonathan, you are the head of patient access for Novartis, and you have been quite in the front line in the partnership with BioME and Novartis. Tell us a bit about that experience, that partnership.
Sure. So BioME is a company I think has been covered by Galen Growth, so people can see more of that, right? But I guess maybe taking a step back, I mean, Novartis has many treatments or medicines for cardiovascular disease, and heart failure is one of them, right? And so I guess, using the term beyond the pill, we really wanted to take a broader perspective of how can we support heart failure patients, right, to drive better outcomes. And I think one area we saw was, again, beyond just the treatment, what can we do for patients after they get discharged in terms of follow-up and remote patient monitoring? How do we help with treatment adherence, right? And so that's really where BioME came in, right? Because they do have a solution. Basically, it's an armband monitor plus a predictive algorithm, right? Essentially, it allows doctors to monitor patients remotely and assess if they are deteriorating, and then that can help trigger early intervention, right? And maybe a data point is because, heart failure patients, especially after they get discharged, there's a very high risk of rehospitalizations if they don't manage their disease symptoms, the medication well, right? It's up to like 50% within 12 months. So it is very significant, right? So again, so that's where BioME came in. So in late 2019, we kicked off a pilot or proof of concept with 150 patients across 3 countries, Singapore, Malaysia, and Thailand. And so that really started in 2020.
Fantastic, great. Thanks for that. Let's dig a bit deeper and explore more like the challenges, the outcomes also of that. Again, depending on how much you can share.
Sure. Yeah. So I mean, I think challenges is I think everyone has touched on. I think one piece certainly was the uptake, right? So you know, as I think Dr. Valerie also highlighted, 2020 probably the worst year to be implementing something new, right? So uptake was really challenging because of COVID. So that's one. And again, another point, a very common point that Dr. Valerie highlighted was the uptake by the patients, right? So this is a solution where, you know, they have to wear an armband, they have to upload their data or sync with their phone daily, and the feedback from the doctors and the patients were that, you know, there were a lot of patients maybe less tech savvy, really not keen, or maybe just not familiar, not confident in doing that. And then maybe one other piece was also around data privacy, right? And I think more and more so people are getting very sensitive to that. And in some hospitals and some markets, it was just prohibitive, right, for us to be able to implement the solution, especially as, let's say, an outsider approaching a hospital, right? So, but I think all in all, then there's a lot of learnings in that sense, right, which I think is extremely critical. I think one, as we looked very deeply into heart failure, it was very clear that there's a great unmet need and a great opportunity to deliver a lot more for the patients as well as the healthcare system, right? If we did these few things, we could really, you know, drop, you know, or reduce rehospitalization rates by a significant amount, right? So I think that alone is apparent that more needs to be done. Then the question is how. And then to the point of sustainability and maybe even aligning incentives with Ronald, and I think everyone has brought up, right, was, you know, Novartis is happy to fund these pilots or proof of concepts, but there really needs to be a sustainable financing source, right? And if you ask me, the first place I would look is who benefits from it, right? And patients benefit, yes, but also the hospitals, the payers, the insurers, right? If hospitalization rates comes down, right? But and I think that's also where more work needs to be done, right? To increase the, let's say, awareness as well as the willingness to pay for these, let's say, supportive additional services.
Fantastic, got it. May I ask, where is the partnership now? At what stage of its maturity, let's say?
So yeah, so we initiated in several hospitals across the things. As I mentioned, the uptake has been a bit slow. So in some places it has stalled even. So I think that's something we really need to work on, right? Which is, I think, highlights the challenges of trying to integrate and implement these things, right, in the real world.
Got it. Thank you for that. Let me go back to Valerie again. Where do you see again the trend and the future of remote patient monitoring going, outside, of course, of clinics? A broader view on that.
I think for me, or at least how I see it, it's really going to be as big as we want it to be. It's how far we dare to dream. But looking at it maybe from the clinician perspective, I think it will be conditions that don't really require an examination where the clinician needs to physically examine the patient. Then everything else, if you think about it, you can theoretically do it remotely, whether it's through video consultations augmented by remote monitoring or any other form. And I think we are moving in that direction. But yeah, I think it really could be anything. And for me, I see value, at least from primary care, in two spaces. One is the chronic diseases, where we've got a whole lot of chronic diseases. Patients are on medications and they've got conditions for years and they don't really need to see a clinician face-to-face all the time. So how do we then ensure that they are empowered to still monitor what they need to at home, and in fact make them sort of masters of their own condition, and they really just come and see us to touch base, to check on blood values, because that's something that maybe right now is not sophisticated enough to get done at home. But in the long run, that might even be a solution where they just get their blood draw done at home. They send it off, everything is in the system. They just need to go through a virtual consultation, and if they're well, they just continue their management. And I think the second group of patients we could really look at is really acute medicine for certain conditions, monitoring of their conditions after that could also be done through remote monitoring. And I think in the space of maternal and child health, that's something that is still very broad. And I think we are looking forward to more solutions for that. At least for where I practice, we've got a lot of underserved, I think, mothers who struggle when they have newborns, probably not financially as able as others, and they do struggle. And how do they then get access to care? Because they can't, while managing 5 kids at home, bring one child to the hospital and then the other 4, and I often see them come to the clinics and they're dragging all 6 of them along. And then we expose the other 5 to whatever conditions they might pick up at the clinic. So how do we then extend such solutions to this group of patients as well? Yeah. So I think it's a whole universe out there. I think it's up to us to dream and decide where we want to go with it. Yeah.
No, thanks for sharing the case studies, which makes it much more human and relatable too. Considering that the industry is present today, what additional support you would aspire to from companies like Novartis, for example, to support such initiatives?
I think we do need end-to-end solutions, and looking at from the public healthcare system, I think we are very stretched in terms of manpower, right? So we've got a very high patient to staff ratio, and sometimes that then limits the time we can spend with the patients that really need us to spend that time with them. So how can, I guess, these solutions help to augment that? How do they help us reduce the need for patients to be physically with us in the clinic, but at the same time not compromise care standards? I think as a baseline, we need to maintain our care standards. If not, so one of the challenges we faced when we first started the sort of our pilots was the care team felt really uncomfortable, and it's normal because nurses, they want to give 120% to every patient, right? So they cannot even accept one reading that's out of the norm. They cannot accept one patient that's forgotten to do their blood pressure reading. So that sense of security, so that we can free up the healthcare providers to provide care for patients who need it face to face, but at the same time ensure that whatever solution we provide assures us that they are being monitored and the algorithms or even AI-driven data can help us to provide solutions to the patients who can then first line self-manage or self-triage and then come to us for those who really need us to intervene. I think a bit of that balance will help. And integration. I think having too many solutions on different platforms, that can sometimes be challenging for us. It's always good to have choice. I think that does help us because everybody sort of wants something different. But how do we then find the easy solution to integrate things so that we don't have to keep hunting on different platforms to find information? Yeah.
Great, thanks for that. Again, staying in on the future. Jonathan, where do you see, of course, the health tech partnerships in this real, going in the near or long-term future?
So from my perspective, I think definitely there will be a lot more and more of these partnerships, right? I think it's becoming more apparent that, I guess when you look at the patient's journey, right, I think we're all familiar, right, from the time they get a disease, he or she gets a disease to the time they get treated. It's not optimal, right? There's so many barriers along the way that impedes diagnosis, referral, access, right? So, and so then if you think about pharma's role in it, we invest in producing newer and better medicines, but it's clear that that's not enough, right? And personally, I really want to, I guess we say we want to disrupt that relationship, but really disrupt how we interact and serve the healthcare system, right? I guess traditionally, pharma companies provide a medicine for a disease. And really what we're talking here today is about providing more holistic solutions to reduce the burden of a disease, right? So how can we, as a pharma, as companies, right, contribute to that more holistically, right? And so I think that's the great opportunity for us to contribute and serve. So I fully expect more and more is needed, right, with solutions like we discussed today.
Great. Okay. Thank you for that. Let me again change a bit stakeholder here. We heard the views from a private player, from a public player. What ventures, entrepreneurs, startuppers like yourself would expect more from these stakeholders? Question for both of you.
Well, I'm very inspired to hear that there's an appetite for collaborations, because I think this is all about building an ecosystem, because everyone will have different skills, and the solution is going to be quite complex, and it needs everyone to work together. So we, from Connected Health's point of view, look forward to working with pharmaceutical companies who have an interest in diabetes, there are various avenues for collaborations there around sort of research where you can find the right sort of mix of lifestyle management together with medications. And so there's post-marketing research that can be done and collaborations. We look forward to collaborating with, hopefully with groups like NHG or NHGP, where we can perhaps run clinical trials to show the effectiveness of our solution as we roll it out. I think that's a prerequisite basically for any kind of intervention. So all of these require partnerships. The third angle, which I'd like to sort of pick up on, is around who pays for healthcare. I think this is a fundamentally important question. And the way in which the payers interact and understand the opportunities and the needs around digital health is going to shape the industry and how it evolves. So, so this is something which I think I would say the governments in many cases need to actively be looking at things from a health economics point of view, which for sure they are here in Singapore, but that may not be true in many other countries, because the government is still the payer of last resort in many cases. But I would say also the insurance companies have to really step up to the market. I hope that we can, as we begin to have discussions with insurance companies around diabetes, we hope that they will shift their sort of mental paradigm to thinking about health economics and a long-term sort of cost-benefit ratios, basically for things like diabetes, for diseases like diabetes, where clearly if you shift some of the cost earlier into the disease and move it towards prevention of complications and better management, you will have significant cost savings from reduction in major complications. And understanding that and working with innovative companies like ourselves to make that happen, and supporting that and finding the right way to bring the right business models and pricing of insurance policies to the relevant patients is something where there, I would say, needs to be a lot more innovation. So this is something that I hope will increase in importance on the agenda of insurance companies. That's my view.
Yep. I mean, we sit in a space that's quite unique. I mean, pregnancy is almost like a 9-month stress test on the body, right? And a lot of conditions that come up during pregnancy are often indicators of maternal health much further down the road. You know, diabetes, GDM, even preeclampsia, which is indicative of maternal cardiac conditions further down the road. And, you know, the stakeholders involves, you know, looking at a patient, not just from a short time window, but from a lifespan point of view. How do we treat this patient? And how do we look into the future, a little bit into the future? And I think from the government, industry, startup perspective, I think this is something we can really do. Take a long-term view on health rather than have a narrow, shorter-term view. And, you know, understanding that there's cost involved, there's a whole host of things involved, but I mean, that will definitely be the ideal state. And second point I wanted to bring up, I think Ronald covered the health economics part quite well, would be data. I think we always get smarter when there's more relevant data, but we only get smarter when we share that data. So being able to collectively use data to progress the healthcare of the country, I think that's significant. And currently, maybe Singapore, it's maybe a little bit restrictive to share data between health systems, for example, you know, even for remote monitoring data to enter the EHR. How do we not silo data, but rather aggregate this data in a meaningful way? And I think that's going to be needed because Singapore possesses such an advantage. We're a small country where we can pilot things on a national scale. We can collect population data much more easily than other countries can. So yeah, just two things, treating patients as a whole from an industry perspective, but also using data and being able to share and aggregate that data. I think it's going to be absolutely key to progressing remote patient monitoring.
Great. Okay. Hope you two were paying attention to such an answer. Okay. I'm done with the questions that I had prepared, but we have questions from the audience, and Chris has been sharing with me the screenshots of such questions. The first one, I think it's more for Ronald and Amrish. RPM is not new. It was available 15 years ago, and I think we were talking a bit about this at the beginning. What has changed to make it essential now since the pilots back then failed? This is quite provocative and challenging, but yeah.
Could I take that first?
Yeah, please.
I like challenging and provocative questions. So
Fantastic.
I think pre-COVID, I think when it comes to medicine and treating patients, sticking to what works generally is the safest option. And before COVID, there was no need to actually change the model, or stakeholders didn't see the need to change that model. And when COVID came around, and COVID patients were being admitted to the detriment of often others, like stroke patients, heart attack patients, we found the need to monitor patients at home. And I think it just broke the mindset of everyone involved that this works. And once it came in and we've shown that it works, Dr. Valerie's pilot is a great example, right? Once we've shown it works, we can't go back, because it's got cost benefits, it's got convenience benefits, it's got clinical benefits. So I think what failed before was the mindset, the collective mindset that, it worked for the past 50 years. Why do we need to change this? Why do we need to change the model of a patient coming to see a doctor? But COVID broke that. Hospitals are no longer the four walls, right? Health is every moment of your life, right? So how do we capture the meaningful moments of those life? So I think that's the difference, in my opinion.
Okay. Yeah, I don't know if you want to share. I mean, if you, please.
Yeah, so I fully agree that COVID was a catalyst here. I think really just my earlier point I made that I think there are many apps that have been developed for diabetes, none of which have really had significant penetration. So the question is, well, why is that the case? And I proposed that was because they've been piecemeal and not been holistic enough. I think that is part of the issue, but I also come back to the ecosystem and the environment, because 10 years ago, let's say, the environment wasn't there. The health tech ecosystem was not what it is today. That stretches from funding, ability for startups to raise money, which is very important, of course, government regulation, the regulatory sort of environment and support to even put in place the relevant regulation for health tech, like in Singapore, for example. It's all very new, not just in Singapore, but the regulation which you need in order to have an efficiently functioning industry just wasn't in place 10 years ago for this. And then, of course, there's the technology advances as well, which in some cases, doing what we're doing is not at the moment, is not hugely high tech, but it has the potential to leapfrog and to jump into AI. And to then this, I think, is another thing which is now made the time now that this is going to take off, where it certainly wasn't 10 years ago. So I'm very much looking forward to seeing that happen.
Thank you for that. I think it's quite satisfying for as a question. It was from George Margulis. Okay, the next question comes from a medical device company, Baxter. Hi, CJ. The question is more around HCP and the difficulty, of collecting and analyzing data. So he's facing more challenges on HCP workload, and is wondering if any of you has faced any similar experience. Valerie probably mentioned that at the beginning, or has any key learnings to share at this point. So how to again push RPM to HCP and have their collaboration. I don't know. Probably Valerie, you should take this one.
Yeah, I'll take it from the HCP's perspective. So I think the learnings we had from the project that we've done is really trying to understand where the pain points are for your healthcare workers, your healthcare professional, and trying to find solutions that reduce those pain points. Then it's easier to get buy-in. A lot of times, at least for us, when solutions were first presented to us, we realized they create a lot more work. And once the perception of the healthcare worker is that it's going to create a lot more work, it's very hard to get buy-in. And you can't sell the solution to your patients if the healthcare worker doesn't believe in it. So I realized that's very important. So that buy-in, take the time to then understand what exactly in that workload is potentially redundant or something that can be easily converted to something a machine can do. Time they need for their usual day-to-day, and you can then I guess more effectively use that time to be put in place or and adopt some of these solutions. So in doing what we did, we actually interviewed, on top of the patients, we interviewed the healthcare teams. what were the things they enjoyed about it. So one was the convenience. So we reduced the face-to-face visits. So for doctors, we only see them once a year instead of 2 or 3 times a year. So that in itself already makes the healthcare worker happy, right? And for the nurses, they know they only need to intervene if they're not doing well. If the patient is doing well, the blood pressure is the same, no alerts pop up on the system, they don't even look at it, they leave it alone, they let it run its own course, and they know that they've saved some workload there to then divert their attention to those who need them to step in. So it's important in the solution to find what are the pain points, what have you improved for the healthcare provider, and once there's that buy-in, it's a lot easier to sell the solution. And then they will be the ones to advocate it to the patients because now they are invested in it, right? Because they want that the added benefit to their practice. It's not easy, and it may not work in every setting. But I think depending on the setting, there will definitely be things that are redundant or areas or pain points that we can help to reduce.
Great, thank you for that. Moving ahead, data question from Johannes. Data ownership is one of the critical pieces to solve. Who can derive strategic value from owning the data, or could even could allow data sharing models with shared data ownership to be explored? This was how it was written. Did you manage to get the question? However, it was on who derives more value from owning the data. And if these data, you could leverage the sharing models of such data ownership. I think, yeah.
Yes. I think it's very important to talk about de-anonymize or anonymizing data because you know, sort of named patient data basically can only be made available to the patient and those people that are immediately caring for the patient. So we ourselves would not, the management would never have access to the named patient data that resides in our cloud. So there are all sorts of securities around that. But if you're talking about anonymized data, there again, come back to my point that sort of the regulation and the regulatory environment, I think, still does need to be clarified in Singapore, especially in terms of collaboration between public and private sector, where there is, I think, to Amrish's earlier point, very much sort of a feeling that that the public sector hoards data. I mean, sort of without, I mean, it's sort of it's slightly cheeky, but you know, there is a greater good whereby if we can put the right sort of regulatory framework in place whereby there can be more sharing of anonymized data, I think this is going to be very important for advancing overall thinking and prioritizing and solving problems, basically. So, but the solution is not easy because the private companies all see that there's huge value in the data and would like to find ways to monetize it, of course. And there is huge value in the data. So I don't quite know what the answer is right now, but I think this is a very relevant issue.
So yeah, I think it's all about managing risk here, right? And it's you know, nothing can be done to the patient's detriment, basically. And I think that's why it's respecting the data privacy laws of, you know, GDPR, you know, HIPAA, and to Ronald's point, de-identifying data, and make sure the data was collected in a responsible way. And that patients are actively aware the data could be used in an anonymized fashion to make systems smarter, to improve services, and so on and so forth. So I think it's all about awareness, consent, and really respecting the patient's right to share that data as well. I think data is going to be the fundamental unit of work, right? I mean, it's no longer moving away from those models where a person is the fundamental unit of work. Data is going to be the source of value of many of these companies, and the patient has to be protected at the center of all of this. So, yeah, I think it's really important that that is at the forefront of everyone's minds when we talk about data.
Yep, I totally agree with that. Breaking news, we are 4 minutes past 5 p.m. I would ask the people who are still online if to stay just 2 minutes longer, if, yeah, and yeah, they are still keeping with us, right? I would like to bring forward the initial idea, so to do a cross-panel question. I know that Jonathan wanted to share some questions with the panelists. Feel free, of course, if you have any questions for each other. That'll be quite an interesting point.
Okay, no, thanks. I guess my question was actually for Dr. Valerie, right? Because I think we've seen besides the really cool example she shared, which I think we're all very impressed in. I mean, I think I've seen a lot of reports with NHG, the polyclinics, right? They were doing a lot of, let's say, I mean, they called it pilots, right? With telemedicine, right? There was tele ECG, eye scans, tele wound care. Maybe your comment on, because I mean, to me, when you look at some of the results that they shared, very, very top line, it was still very impressive, right? Very significant reductions in the needs to refer to the specialist centers. Often, I think with wound care, they managed to manage a lot more patients from home, right? By just sending photos. And I mean, I guess, is there anything more you could share on that, right? In terms of how it's going, which I guess steps a little bit, some of it is remote monitoring, some is just more broadly telemedicine, right? Is there anything else that you're seeing that's working well?
So actually, we've got quite a full suite of telehealth solutions. As you shared, some of them are between provider and provider, like tele-ECG. So we share the ECG results with the cardiologist, and we assess, does this person need an urgent review? So we get an expedited appointment for them, or can this person just be monitored in primary care? Or does this person then go on to have their usual routine review at the cardiologist? So it has saved a lot of visits for patients. And at the same time, it's empowered the family physicians to then look at the ECGs and say, okay, I'm quite sure and I'm quite certain now that this patient's going to be okay. And we then redivert resources to the patients who really need it. So those who need urgent reviews, they go in for urgent reviews. So these are some of examples between provider and provider. And I mean, if you can think about solutions in the long run, if you can even substitute, I guess, the time of the cardiologist, where there's an automated system that can read some of these and do risk assessment, that would help that solution even more. We've also got things like telewound, so they monitor their wounds over time at home. Some of the younger patients who can just do their own dressing, so they just do it from home. So that helps save them coming down to the clinics. And we've gone even further to even things like tele-dietetics. So we do dietitian counselings through video consultations. We do tele-psychology. So even with your psychologist, sometimes it's busy, you need a session. You want to do it from the comforts of your home. Actually, that's also possible. So we do have a full suite of them. Not all of them need remote monitoring, as you mentioned, Jonathan, but I think that's really the direction that we're going towards. Of course, COVID being that big catalyst of it and wanting to keep people safe and at home. But some of these solutions have been working well. It's just how then, over time, how do we integrate all of it and continue to make the solutions more effective? Yeah.
Was it okay?
Yeah. Did it answer your question?
Very nice. No, thanks for sharing, right? I think it's very inspirational, and I think
definitely.
it gives a lot of opportunity for all the other stakeholders, whether it's pharma or other health tech, right, to see how we can contribute or, let's say, piggyback on those initiatives as well.
Okay. If there are no more questions, I would close the session for today. Thank you, everyone. Amazing conversation. Thank you, Dr. Valerie, Ronald, Amrish, and Jonathan. It was a pleasure talking to you. Thank you to the audience who stuck with us until the end and for all the amazing questions. The session will be available online as probably next week at the Galen Growth YouTube channel. And just stay tuned. We have, again, other sessions upcoming the next month. Again, thank you so much, and have a nice day to all of you. Thank you.